We're going to start off the session. We had done this before. I'm just curious, how many people use 3-Mensio, or how many do their own analysis? I mean, I do think it's important that if you're doing a TAVR or a TAVI, that you look at the anatomy, because the challenge is how the TAVI device interacts with the annulus is really quite different in one valve versus another, and that's what predicts outcomes. And stroke, PVL, root injury, sort of significant complications. At our center, we have 3-Mensio. We don't send our data out for analysis. We look at it ourselves, mainly just from a logistics standpoint. It's just easier because we look at and it's not that we know what the right valve is for an individual patient, but we choose between. We have 3 approved devices in the U.S. with Portico. With Navitor, Evolut FX Plus, and Sapien 3. And so part of the decision making about which valve to use depends on what we think of the CT. Now, we don't really know for certain what valve to use, but we usually have gut feelings based on annulus size, LVOT, calcium, and everything else. So I just want to go through a couple patients real quick. We use this 3-Mensio. I think Edwards for Lemmy use their laptop. And it's become automated and easy. And even if you're sending your CTs out for analysis, I encourage you, when the company comes with the device on the day of the procedure, that you go through the analysis yourself. And so the first thing is to create an annular plane. And there are different ways to approach it. I'm going to just show you 2 different ways. What I like to do, so this open circle corresponds to the open circle up here. So I see the root here. I put this is roughly in the middle. I rotate around and I see where the bottom of the leaflet is. And you mark the base of each cusp. And so I put a dot there. I'm going to go to the base of this cusp and put a dot. And I don't need to be perfect because you can adjust it. I'm going to go to the base of this one and look at the lowest point as I scroll around. And in this top left, put the dot at the base. So now you have 3 dots, so you've defined your annular plane. And I scroll up. Do the leaflets all appear at the same time, roughly? So I'm pretty comfortable that I have a good annular plane. The other way that people often do it is slightly different, and each is fine. What they do is on this screen, they go down till they see let's just focus on the right here, till the right disappears, which is, we see the cusp here. Going to go down till it just disappears. I'm going to make this, actually I'm going to make this uneven just so, actually I can't, okay. So that cusp disappears and I'm going to put the dot right there. I'm going to scroll up again till this cusp just disappears, put the dot. Scroll up till I see this cusp, and where it just disappears, I put the dot. And you do the same thing. Either way, you're basically marking the base of the cusp. You can do it either way by putting it up here or down there. So you mark those, and then you then hit confirm. And so now I have my annular plane, and now I can do my analysis. So what am I looking at? First thing is area of the annulus, and you can do automated, and you can adjust it if you do it automated. It's not always perfect. If you don't do automated, you can delete this and say it wasn't great. I could do my own tracing. And you're trying to find that transition of the LVOT to the muscle. And so there's some variability in it, but I get like 488 here. You can look down. Does the LVOT get bigger? Measure 3 millimeters below, which is generally our landing zone, and it does flare out a little bit. Then you look. What is the pattern of calcium? There's calcium in all 3 leaflets, relatively symmetric. Then I look at coronary heights. And when I get to coronary heights, there's 2 different ways I look at it. Simply, when the ostium is there, there's no leaflet. This, it's at around 12, but there's not a leaflet. That reassures me quite a bit. And so, but then in the double oblique view, you can change this. So this is stretched vessel. So there's going to be artifact on that. So if you do a double oblique, this is sort of looking at it in the anatomically correct plane. So then I can measure in this view as well. see right there, sorry, a little bit of a glare on the screen, but you can measure to the bottom, I get about 11.3, measure to the top, around 15, and then you can, and that's on this side here. Then I can rotate this around till I see the right coronary, which is right there. You see the right coronary, and I can measure there as well. So you get coronary heights, you get those measurements, you're looking at the height of the sinus. This is where the STJ is. The sinus is about 19. You could measure STJ dimensions, and you look at the ascending aorta. So very quickly, you have a sense of this anatomy. And so if I look at this anatomy, it's a relatively straightforward, low-risk anatomy. The area is around 488, 500. LVOT is not calcified. The coronary heights are good. There's no STJ calcium. This is a relatively straightforward case and would feel very comfortable with any of the devices. You put a 26 Sapien. I didn't see the perimeter here. 83 something, I think. So on the border of a 29 Evolute FX, it'd be appropriate for a large Navitor. It's a straightforward anatomy, good for all anatomies. And so that looks straightforward, and then you could just do the femoral as well, just to get a sense. Again, open the thing, click here, and just put femoral, and you put one dot somewhere on the aorta. It highlights it. If it doesn't, you can do it manually. But then you put 3 dots, one there, and then down in the SFA, and it will segment the vessels. If it's not correct, you can move any of these things around. Sometimes, if it's not a good contrast scan, it will not. And then you can rotate around the vessel. You can see where the calcium is. You see there's some calcium at the common iliac, and then I can go to the right, scroll around. It looks pretty good, like central line access. Hit confirm, and then you get a sense. You can scroll up. You can look at the calcium. This, again, relatively straight, not tortuous, minimal calcium, reasonable access point at the femoral head, relatively straightforward case. And then I always, I can't figure out how to do it on this. I get it on my, oh, here it is, 2D. And I just scroll the anatomy once. I'm looking for sentinel. Here, sentinel anatomy looks good. It's not bovine. The aorta looks good. There's some atheroma on the aorta, but not terrible. And scroll down. Just get a good sense of what the anatomy you're going through. And that's a relatively straightforward case. So, but it's still helpful to do it, because I know the issue is if you get in trouble, it's important for you to understand what the anatomy looked like when you got into trouble. So then you sort of understand. I'm going to show some other a couple different cases. So we're going to go through this. And this is, you can scroll up and down, and you can see this is a bicuspid. Oh, is this the right one? Yeah. But you can still, there's 3 cusps. Even if there's a raphe, there's 3 cusps. And you can still use the same method here with placing the dots. So, and you can see you can still get the annular plane that same way. There is this setting where you can put bicuspid, where you place 2 dots. When there's a type 1 bicuspid, and I don't know if others do differently, I generally still place the 3 dots. Oops, I messed it up here. Let me do it again. Because there are 3 cusps. So let me place these 3 again. So we can do the same. I'm not going to focus on it. Measure the annulus. It's around 416. But you see here that it is fused right and left. More calcium on the right and left, less calcified on the non. There is some calcium in the raphe. And then you measure the sinuses in these type of anatomies. And again, sorry. The sinuses are relatively generous, 29 there. This one's definitely smaller. It's around 25, 24. And people measure sinuses different ways, but I'm worried about root injury. And so, one of the concerns I have when there's a heavily calcified raphe is if this raphe isn't going to open, the valve's going to shift towards the non, and is there room for the valve to sit? So again, looking at calcium patterns, looking at coronaries, and here again, the right coronary here you see is very high at around 20. The right coronary comes off at the STJ. So no risk of coronary of impeding the right. The left here comes off high as well, as you see, at around 13. I scroll down, the bottom of it is around 11. So relatively large sinus, the coronaries are high, and there's a calcified raphe, but not terribly calcified. So this is anatomy, again, I would feel comfortable. From a sizing perspective, if I was doing a sapien, I'd do a 23. An evolute, this is on the border, but it would probably be a 26 for me still. But you could debate it, because you might make it larger to a 29. But then there are other anatomies that are much more challenging. I hope I'm getting the right one. So you see here, this is a very complex anatomy. The aorta is rotated, and this is a type 0 bicuspid. So this, I'm going to put 2 dots like this. Oh, sorry, I didn't change bicuspid. So I put, and what I generally do is I put the 2 dots here and here, and I come across, and then and see, again here, it looks pretty good. Again, you can scroll up and down and see if the valve plane disappears. And this looks reasonably like a good plane. Now, this aorta is very angulated, rotated. This becomes a very challenging anatomy to cross with the valve. And I know that up front. And you see the area here is 441 and 75. But you look at the coronary takeoffs as well. They're a little bit abnormal, but they're high. The left is there at 15, the right is there at 20. But it's a type 0, but there is a calcified raphe as well. So this one is definitely a more challenging anatomy. Now, one thing to point out, in this patient, it's the 46% phase, so it's in diastole. Diastolic measurements in general are a little bit smaller than systolic. So when you get the CT, I like to make most of my measurements in the 20 or 30% phase. But if the 20 or 30% phase has artifact, you got to choose a phase without artifact. So I might go to the 70% because they had less artifact. But you have to keep in mind that measurement you're getting, because you're normally sizing to systolic measurements, and that measurement you're getting in diastole may be a little bit smaller. So there is some, like here, this is getting to be 440, and I'm curious what maybe I'll ask Ramesh or others. In anatomy like this, how would you choose? Oh, quick question. Anatomy like this, what kind of valve would you guys choose? And because it's a 40% phase, area is 440, perimeter 75. If you had access to all the different valves, because this could be a 23 sapien, would you balloon size? Would you, it's a type 0, it has a calcified raphe, would you be more aggressive and do a 26? Because the sinuses are big. These are the sort of things, when you look at the CT, you're trying to imagine how the valve is going to sit. And I don't know, when you look at CTs, do you both sort of look at them and say, what valve am I going to use? How is this valve going to anchor? Do you use the virtual valve function? You can put a virtual valve, and if I put a 23 sapien here, this is what it looks like. I mean, how much are you using 3 Mencio to choose your valve size? Can we turn the mic on? So, just take the last few minutes there's about 3-4 minutes left.
No, but absolutely, 3 Mencio is very important for us to analyze this properly. Putting a virtual valve in that plane helps to see whether we are undersizing or oversizing. I think the choice based on how you believe in SMART trial, whether smaller annulus will be okay with the sapien valve or evolute valve or self-expandable valves is something always a debate that we are having nowadays. But I still think that 23 sapien in this patient would be fine. We don't, as long as it is not causing too much problems in coronary obstructions or aortic root hematoma risk is not there. I think better to go with 23 sapien. If we can't put 23 sapien, then only I'll think about whether self-expandable valve has a role.
No, I agree with you. I think the only other advantage we have in the Indian situation is this intermediate sizes. So probably a 24.5 would work perfect for a balloon expandable in this particular anatomy, or as you said, a self-expanding. So that intermediate size works well. Otherwise, I think 23 plus 2 ml should do well rather than undersizing 26 minus. I prefer to go 23 plus 2.
So, I think these are the challenges. I mean, I've used 3-Mencio a lot, but I think we're going to get away from this in the future. I mean, there's things like DOSI simulations. In the US, that's been CMS approved. DOSI simulations takes the CT scan and has characterized tissue properties and simulates how the different valves will expand, PVL, risk of root injury. So I think in 5 years, we'll move on. I think 3-Mencio is great, but it's important for us to use 3-Mencio now to try and integrate, is the anatomy suitable, what size roughly, what are the high-risk features. If you have a ton of LVOT calcium, then you're at risk for PVL. If you have a ton of STJ calcium, you're at risk for root injury. And we can give patients a better assessment of risk, because that first patient I showed you, I'd tell them they're very low risk for any complication. But as I start adding features, I'm going to change my risk threshold to tell the patient. And in a low-risk patient with horribly calcified bicuspid valve that you see, when you look at this, that's a patient that should go to surgery. And so I think looking at the primary data helps you make the decision, not about how to treat that, about what valve to use, but how to treat the patient, TAVR versus SAVR. And I think it's important to look at this imaging. I think in the future we'll have better stuff with AI and simulation to help us better understand what the true risks are. But for right now, the only way to simulate it is for us in our minds to look at the data primarily and to integrate it. And not be hesitant when you see bad anatomy to say, I'm not doing that case. When you look at the anatomy, because you might get pushed to do a case, but say, I'm not doing that case, that patient's low risk, 65, with horrendous calcium, that patient should get surgery. But any other thoughts?
In your patient population, how much of DASI simulations are you using, Susheel?
So we're struggling right now because we're getting our hospital to integrate it because they got CMS approval, but the billing mechanism hasn't been sorted out. So we've only sent the truly high-risk ones that we're worried about. But it should be similar to heart flow.
Yeah.
Because if the radiologist gets the scan, in heart flow in the US, it's a billable procedure for insurance. The radiologist can send the scan, it's analyzed, and the coronary tree comes back. The idea with DOSI or FEOPS or whichever company is going to be the same. You get your TAVR scan. If it's in the US, for example, it's a reimbursed analysis. It will be sent out, and you'll get back, here's the risk of root injury with a 26 Evolut versus 29 Evolut versus 26 Sapien. What is the risk of PVL? And you can have a more honest conversation because that's where it's getting us with AI and all these things.
Yeah, I think that's wonderful to do DASI simulations, and we should be proud because this is also an Indian guy who invented it, number
Yes.
one.
From Georgia Tech. Yeah.
Especially in TAV and future, what we are thinking about coronary obstructions or how these valves embolize or how they sit. I mean, recently, I think I might have texted you, Susheel, I don't know. TAV on a patient, actually, they undersized the sapien valve in a previous 34 Revolute. And so that valve embolized in our center and caused the patient to have an emergency surgery and ultimately demise. So I think that could have been prevented if we actually had a DASI simulation in that patient, I think, So that is where we are moving towards in the future. Agreed.
All right, so I think we'll go on to our next speaker. Dr. Chopra is going to present a case of a type 0 bicuspid, and then we'll have a discussion. And again, I know we should have mics, people for the audience, and if people have questions, raise your hand, and we'll get a mic to you. And we want this to be interactive, and that's the goal for this session.